Hey, welcome to the first webinar of this four-part series on promoting healthy food choices and physical activity in rural American Indian communities. This webinar will be recorded and available on the website. I'm Douglas Tarrin. I'm the director of the Western Region Public Health Training Center. I'll be moderating this webinar today. I want to give a special welcome to the folks from the Western Regional Public Health Training Region and the Southwest Telehealth Resource Center. Also welcome to fellow HRSA grantees and all other participants. We're pleased to offer continuing education credits for this webinar. You'll see that's 1 credit for nurses, 1 for chess, and then 1 for dietitians. Oops. I'm just going someplace else. There. A disclosure about nursing education information. All planners and presenters for this activity have no relevant financial relationships to disclose. The continuing education information is at the end of the completion of this. Please present for the full, be here for the full duration, complete the online nursing evaluation, and that's available at the website cne.nursing.arizona.edu. A couple other recommendations for having a successful webinar is please mute your phone and or computer microphone. The time is reserved at the end for questions and answers. Please fill out the post-webinar survey, and the webinar is being recorded, and here's the websites so you can look at this afterwards. The other thing you'll be able to do is email us or text us questions for the Q&A. I'd like to introduce a colleague of mine for at least the last 25 years, Dr. Nikki Teufel Shone. Dr. Teufel Shone is a professor and program director at the University of Arizona Mel and Enid Zuckerman College of Public Health, Family and Child Health concentration. She co-leads the National Institutes of Health funded Center of American Indian Resilience that strives to understand, integrate, and disseminate culturally informed strategies to achieve health equity. For 30 years, she has worked with several tribes in Arizona, New Mexico, and Oklahoma to develop effective health promotion programs that support healthy food choices and physical activity to prevent diabetes and heart disease. She and her colleagues in tribal communities have emerged as leaders in community-based participatory research and designed and implemented research service programs. I also like to mention that she has received the 2015 Native Research Network Excellence in Training Award, recognizing her work with young American Indian scholars, the 2010 John Pike Voices for Change Award, granted by the American Diabetes Association National Indian Health Board. And she also just came back from a Fulbright in Canada, where she was the Norlean Foundation Distinguished Research Chair for 2015 and 16. So at this point, I'm going to turn this over to Dr. Teufel Shone.
Great, thank you very much, and welcome to all of you that have signed on to this webinar. I think it's a great honor that I get to go first in this 4-series webinar, and as a result, I've decided to talk a little bit generally about American Indian health and how some of the funding streams have actually driven some of the approaches to nutrition education, and even to some degree the physical activity efforts that have occurred in Indian country over the last 10 or 20 years. I will be talking at the later part of my presentation about work specifically with the Wallapai tribe, which are in Northwest Arizona, and they have really been true partners in us exploring what are creative ways, what are asset-based ways to promote food choices and physical activity in their rural community. And on that note, I would like to thank my colleagues in the Wallapai tribe. These are not only the colleagues I've worked with in that community, but also the youth of that community who have been very straightforward and direct in letting us know what has worked and what has not worked with them. And I think they've been some of the best educators and partners for the projects that I've had the opportunity to work on, because they've been also, their enthusiasm also lends us to think about the assets that there are in any Native community. I wanted to provide a little bit of background about American Indians and Alaska Natives, and I'm doing this because I'm not quite sure who the audience might be. I recognize that some of you may have worked in Indian country for decades and are quite familiar with this information. For those that are new to working with American Indian and Alaska Native populations, I thought this might be useful information. You can see there that there really are over 500 federally recognized tribes or nations. And American Indians are the only U.S. minority that really need to be card carrying. And they have what's called a CIB number, or Certificate of Indian Blood, and it really identifies whether they are eligible for healthcare services or whether they're available for some educational opportunities. So unlike other minorities who are able to sort of decide how they want to answer some of these questions about ethnic status, there really is a process, a very federal formal process for this designation. We see on tribal enrollments that there's about 250 million individuals who are on tribal enrollments, which means that they do have CIB numbers and they are recognized by the tribe that they've identified with. And for some individuals, you have to make a distinction about which tribe you would enroll. If you have heritage from a number of different tribes, you cannot be enrolled on several tribal enrollments. You can only be on one. And so this is becoming increasingly an interesting issue for individuals that have multiple tribal allegiances, that they have to enroll in one particular tribal enrollment list. We now know, as of 2010, maybe a little bit earlier, more than 50% of American Indians that do have CIB numbers are living in urban areas, which sort of shifts the approach that we might use in terms of health education, nutrition education. We do also know that the level of American Indians that are living below the poverty level is higher than that of the national average, but the attainment of a school education is actually fairly high in American Indians, and this is for a number of reasons. One, that there are federal schools, federally funded schools that students can actually travel to, whether it's in their communities or outside the communities, but the schools are available for those that want to continue with their high school education. And to their credit, many American Indian communities have now developed policies that employment within their communities needs to have a high school education, which has really been critical in keeping the high school education level high. Then you can see there the mean age is a bit lower than what we have in the US mean. The reason I'm bringing up some of these demographic features is because they really end up being drivers of the success and the approaches that we might use in nutrition education. For example, people may be living at a relatively low level of economic power in the sense of being below the poverty level, but they clearly be fairly well educated with high school education and maybe some college education that they've been able to get through tribal scholarships. I provided this map just to give you an idea of where American Indians are distributed, both within the continental United States as well as Alaska there. I don't think the colors came out very well in Alaska. But one thing that is worth acknowledging is that Native Hawaiians do not follow under some of the same kind of federal funding that's available for health education and health care as there is for those living in the continental United States and Alaska. I want to talk a little bit about Indian Health Service, and the reason for that is because I think that much of the work that's being done now and in the past decade or two has been funded by Indian Health Service. So they are certainly driving many of the approaches that are being advocated to tribal communities as they move forward to address some of their chronic healthcare conditions that are influenced by food choices and physical activity. Since 1955, Indian Health Service has been the federal entity that is essentially providing health care under federal treaties, court decisions, and executive orders to American Indian communities. And you can see that the photos I've provided, this is if you receive services yourself from Indian Health Service. Generally, one of the characteristics throughout the nation is that waiting times are oftentimes large, which I think reflects the limited income or the limited resources that Indian Health Service has available to them to provide, to carry out the treaties that have been decided between the tribes and the federal government about health care. There has been an opportunity within tribal healthcare systems, those that are managed by the tribes themselves, to take on the management of their direct healthcare programs. And this is oftentimes referred to as 638 because it was determined through the Indian Self-Determination Education Assistance Act, PL 93-638, that American Indians should be able to direct their own health care. This has taken a quite diverse layout in the nation in terms of how tribes have responded to this. There are many contract tribes, which means that they have they've applied to the tribal government and have developed a plan to take on their healthcare parts of their healthcare services. Other times they will allow healthcare services to continue to be managed by Indian Health Service. There are less compact tribes in the West than there is in the plains areas in Oklahoma, and those tribes in Alaska have taken on compacting much more enthusiastically and have taken on more of their healthcare programs. The programs that I've worked with most have been contract. So the programs are in part dealt with by the tribal administration and some care by Indian Health Service. I want to talk a little bit about the economic disparity in terms of the federal funding that's available to Indian Health Service. And this is a per capita estimate that was provided in 2010 through the Department of Health and Human Services. And these means that are provided in terms of services certainly illustrate that Indian Health Service has been underfunded in terms of its per capita expenditure for healthcare services. Given that this picture of funding indicates that Indian Health Service oftentimes is in the business of triage and has less been able to expend funding on prevention services, which is oftentimes where nutritional education resides in healthcare programs. The final piece there to that slide that I wanted to provide was that the estimate from Edward and Patchell's work in 2009 is that the medical care costs for individuals with diabetes is quite high, over $10,000, but that is not the kind of allocation that Indian Health Service has available to it, given the growing costs and numbers of diabetics within the American Indian communities. And I wanted to talk about diabetes because I think it is Indian Health Service's special diabetes programs for American Indian and Alaska Natives, which has really driven a lot of the diabetes education and nutrition education that is available in tribal communities. And in fact, is the kinds of programs that I've partnered with predominantly in the work that I've done in Arizona and New Mexico. And I wanted to highlight, although many of you may know this, that diabetes is a relatively new problem in American Indian communities. And actually in the 1960s, what was being reported in the scientific literature was actually protein and calorie malnutrition, marasmus and kwashiorkor. And so it's quite startling that just 40 years later, American Indian rates of diabetes increased to become 4 and 5 times more common in American Indians than in all races in the US. Now the prevalence and the rates vary tremendously between tribes, with Alaska Natives reporting the lowest incidence of diabetes and tribes within Arizona, specifically the Gila River Pima, reporting the highest rates of diabetes among American Indians. This slide is intended just to sort of give you a refresher. If you don't work in diabetes programs exclusively, or you're actually coming into nutrition education from another venue, not through diabetes prevention or education or management, just to sort of remind you that that diabetes is characterized by a high level of blood glucose, and that it does have a strong inherited connection. But we do know from predominantly literature that's come out of American Indian countries that although there's a strong genetic component, we know that individuals who have diabetes in their families have been able to manage and even prevent diabetes with a strong behavior modifications that in which they're really committed to making some clear food choices and physical activity that would help prevent or well control their diabetes. We do know that food choice is a risk factor and can contribute to the mismanagement or the lack of control of diabetes symptoms. And generally those food choices that are approached in a diabetes program, whether it's prevention or management, are generally foods that are high in fat and low in fiber. Certainly the tribal diabetes programs have been champions in also addressing the sedentary lifestyle, really working hard to get people to take on habitual physical activity so that they can manage their body weight relative to their height, which we know is a huge driver of some of the risk factors and expression of diabetes. The other concern in terms of diabetes risk factors that is influenced by both food choice as well as genetics is the pattern of fat deposition that occurs frequently in American Indian populations, and that idea of centripetal or abdominal fat deposition that has been linked to high levels of cortisol, which it's almost a chicken and the egg kind of discussion here of whether the fat deposition actually causes the high levels of cortisol, or the high levels of cortisol are actually driving the pattern of fat deposition. We also know that the centripetal fat deposition is also influencing muscle tissue receptivity to insulin, which contributes to insulin resistance. So my work very much has looked at food choices as a way to manage the high rates of high body mass index or high body weight that may be driving diabetes outcomes and control. The other thing I'd like to do, so we have a little bit of background on diabetes in Indian country. I also think it's critical to think about how diabetes prevention and management has been funded in Indian country, because this is what has driven a lot of the approaches. And we know that there have been some longitudinal studies around diabetes, both in prevention and management. And I won't run through each one of these, but you can see since the 1960s, federal funds have gone into Indian country, predominantly controlled by non-native researchers, looking to understand not only how to better manage diabetes, but also how to prevent diabetes. And probably the foundational work in looking at prevention of diabetes in American Indian youth was really the Pathways program that was funded by the National Institute of Heart, Lung, and Blood, looking at diabetes prevention in 7 different tribes nationally. So it included tribes both in Arizona, New Mexico, as well as South Dakota. So it really provided a lot of information about what was feasible in a school-based setting in Indian country. So that's working with schools that may or may not have resources such as physical activity equipment, recreational equipment, or nutritionists. So it really provided a lot of information about prevention. We also know that when the DPP, which was the National Diabetes Prevention Program, which looked at the role of both food choice and lifestyle, as well as medication, predominantly metformin, in communities, that there were 2 American Indian communities that were represented in that national DPP program. What's interesting is that the outcomes for American Indian communities was that the lifestyle coaching branch or arm of that randomized control trial ended up being quite influential in Indian country, and so what has taken off in terms of driving a lot of the diabetes prevention choices that have occurred in tribal communities. As a result of not only the DPP, but also the Balanced Budget Act in 1998, Congress actually mandated the special diabetes programs for American Indian and Alaska Natives. And the SPDI programs have been critical in driving many of the community-directed programs in Indian country. In 2004, there were 2 additional programs that were funded, and those were actually competitive funding, and they looked at both diabetes prevention and heart disease risk reduction in Indian country. And those are just concluding now in 2016. So if you look at that time frame, that means that the SDPIs have been around for almost 18 years, which has been 18 years of funding that has gone to tribal communities, and that was the recipient of the SDPI money. 18 years of funding that's gone into these communities. The communities could elect to administer all the funds within a tribal program, or they could subcontract out some of those funds to include Indian Health Service or whatever clinical services were available to them. So I think we really have 18 years of data to look at to see what has worked and what has not worked. Of the programs that have been funded through the SDPI programs, many of them have been tribally guided and culturally based. So in most cases, tribes have continued to manage the programs themselves. They may contract for a portion of a RD or a medical provider to help with particularly the management and the case management of diagnosed diabetics. They may have an RD that they funded to work in a school-based setting, but the programs are still been under the guidance and management of tribal communities themselves. Now, in an effort to support the tribal programs, Indian Health Service has identified what they call model programs, which are programs that they featured on their website when Indian Health Service has a conference, whether it's a national or a regional conference. They frequently invite representatives, staff from the model program, so they can talk about how they were able to maybe overcome limited resources, challenges with recruitment, of engaging the community. So Indian Health Service has done a very thorough job of featuring and showcasing these model programs that have been able to demonstrate successful strategies. Indian Health Service has also identified what they call best practices, which are 16 strategies designed to manage the diabetes. So you can see from that last bullet there that the focus from Indian Health Service, given their expertise in clinical care, has really been about the management of diabetes. So that's really been a strong message that tribes have heard about managing diabetes. But the tribes themselves oftentimes are very focused on looking at youth and looking at programs that might address the prevention of diabetes. And that's some of the approach that I want to share with you in my work with, my more exclusive work with the Wallapai tribe. So the common core of many of the programs nationally has been using the best practices that IHS has provided. And in fact, in the funding, when you apply, you do the continuation report for the SDPI program, you have to explain which of the best practices you are using. So if you're a program that has chosen to focus very much on prevention, you may struggle sometimes to figure out how you're fitting into the IHS umbrella of best practices of diabetes management. In fact, your focus is prevention. There has been a lot of focus on health education. There's been focus on food choices. Oftentimes, the recommendation of Indian Health Service when they provided background for the SDPI funding is to consider hiring an RD, so you have one-on-one counseling, do healthy cooking classes, and offer recipes. and oftentimes, if possible, to change the selection in local stores. Many tribal programs have decided to develop local fitness centers, which is a wonderful change in the environment in even very rural, small communities, that they'll have a fitness center that's open to all community members. And if you've had the opportunity to work in SDPI programs, you know that community fun runs and Just Move It's and those kinds of really community-based interventions have become a real hallmark of these tribal programs. But the issue of case management for individuals who are high risk for diabetes and actually have diabetes continues also to be a core of many of these programs. Unfortunately, in this time period, though, since the 1998 beginning of the SDPI programs, we're not seeing a decrease in the prevalence of diabetes by any age group in American Indians. Now, some of this increase in rate is probably a result of the SDPI funding, in that now there are more resources to do more surveillance in the community, so that at many community health fairs, at other kinds of open community events, you may see the SDPI programs in those communities actually having a booth that allows people to get at least a random glucose finger stick, which would allow the staff to alert the individual that they might want to go to their local clinic and get and determine whether in fact they have diabetes. So in other words, a high random glucose would alert them that they may be at risk. It certainly isn't a diagnosis. So that outcome of the high rates might be an outcome of the more resources that have been put into diabetes education and awareness. And it certainly has been observable in tribal communities over the last 18 years that when the SDPI programs started, very few people were actually talking about being diagnosed diabetics. And there's a wonderful article by Jenny Joe, who is now retired faculty here at the University of Arizona, about how a diagnosis of diabetes was really hidden for many people until these SDPI programs were initiated, and there was a lot more awareness and a lot more openness about not only is this a health diagnosis for an individual, but we should be aware that it's becoming a community program and should not be just seen as an individual burden. My question to those of you that are watching this webinar today is, does this 35-year trend that was projected in the last graph suggest that diabetes prevention efforts are making progress? Do we think we're doing a good job with the kind of efforts where we have used sometimes a one-on-one approach to diabetes management and prevention? And has the strategies and maybe the innovation in tribal communities been able to really come to the forefront and do the best they can do in their communities? And I guess my second question would be saying, are we okay saying that the impact of the efforts up to this time will take time? And it's a sort of my way of saying, do we think we're making progress? Do we think that the kinds of strategies and approaches that we've used in nutrition education, which is really a hallmark of the diabetes education, is it been successful? And so some of my thoughts are to you as working professionals in these arenas is, what are we missing? What perhaps are we not thinking far enough out of the box? Could we explore more upstream approaches? I mentioned earlier that there's some very emerging work looking at cortisol levels in individuals who may be at risk for diabetes, and the idea of how much is stress driving some of the risk factors for diabetes. And are we looking upstream enough, or are we just waiting until individuals are diagnosed with diabetes or diagnosed at risk, and then we decide to provide some nutrition education? The other question is food type availability the major driver of food choice? We certainly know that there have been some work that has been done by Joel Gittleson at Johns Hopkins, in which he's worked to change the food choices in the foods that are available within the Navajo Nation and other nations in the US and Canada as well. We know that many SDPI programs have been working with the grocery stores in their communities, trying to change the food choices that are available. And despite changing those environmental cues, we still don't see a tremendous change in some of the food behaviors in Native communities. So is it, in fact, the food choice that are available, or are there some other drivers that we should be considering? The other question is it access to recreational resources? Is that a major driver of physical activities? If you've been working or if you live in tribal communities, you know that the fitness centers, the number of increase in fitness centers has increased tremendously in tribal communities. And, you know, are enough people going to those fitness centers, or are people who are already exercisers using those facilities, and those facilities are not meeting the needs of people who are not regular exercisers? Are we doing enough around that? The other thing is education has been used frequently as a way to drive what's going on in terms of nutrition and diabetes education. And the question is it the magic bullet? Is understanding about good foods sufficient? And have we focused too much on the individual approach to nutrition education? And in my case, my work in diabetes prevention, have we not looked broadly enough about the community approach? So these are some of my thoughts, and I'll talk mostly about the third bullet in the remainder of this webinar, but I wanted to get you thinking about the concept of positive deviance. We do not spend much time thinking about who does not get diabetes. That those individuals have certainly developed personal strategies for making good food choices, being more physically active in environments that might be cueing you to not make those good choices. So we need to look more at those not getting diabetes. We perhaps need to look more about stress as a driver in diabetes risk factors, and there's only been very limited information and approach to this. In fact, some of the model curriculums that have come out of the SDPI program don't even mention emotional eating and stress-driven eating. What I'd like to talk about is the application of local assets, the idea of how could collective efficacy and resilience, how can cultural and social capital, and how can formal and informal leadership be leveraged to drive healthier behaviors. I provided a few definitions here so that we're all on the same page about what I'm talking about in terms of efficacy. Resilience is certainly emerging more in the last couple years as a way to take an assets-based look at community health and community approach to acute stress, to chronic stress and adversity. And I also wanted to raise your awareness about social capital, which are the networks that are alive and well in Native American communities. Most Native communities, people very much recognize their connection to each other, whether it's having started Head Start with each other, and so they've known the same people for the last 30, 40, 50, 60 years, as well as family connections. And that those connections oftentimes are not recognized in many of the health promotion programs that we run in Native communities, yet they're huge sources of strength. If you're aware of the enthusiasm to use social media in tribal communities, you know that Facebook and Snapchat have become really important ways of people connecting in tribal communities. There's also the concept of cultural capital, of that idea of sharing similar values, linguistic styles. Even if those linguistic styles are in English, we know that there are certain ways of talking about issues and talking about your health, your food choices that are distinctive in Native communities. And so using some of those, how are we leveraging those to improve our outcomes? And those are really the lessons that I think I've learned through my long-term relationship and partnership with the Wallapai Tribal Health Department. And so I want to share some of those with you, not only in terms of how we've done some formative assessment, but also what kinds of things we've done in terms of developing innovative programs and approaches, and what kinds of changes have been made at the policy and the normative level. The Wallapai Health Department has been a huge advocate of how do we make health behaviors normative? How do we not focus so much on the individual, but really understand how we as a community advocate and motivate healthy behaviors? So the Wallapai tribe is there marked with a red arrow up in the upper left-hand corner of the map of Arizona. Its northern boundary is the Colorado River. And there's about 1,600 people on this 1 million acre reservation. Almost everybody lives in one town. That town is Peach Springs, Arizona. You may have driven through there. And you can see it's a young population, and that the level of poverty is quite high in the community because there's limited resources for employment, although the tribe has been really stellar in moving forward and trying to create resources for their community. There are a number of services available in the community, and you can see there that they have management of their school system. They do not have a high school in the community, and so students either go to boarding school or they go to a school off reservation. They have management of a small grocery store, which in recent years they've taken huge strides in changing the contents of the inventory in the store. Just to kind of give you, again, a little more to context, their northern boundary is the Colorado River. They do have a river running company that is run by the tribe, and they are also the tribe that has the skywalk over the Grand Canyon. So there is a tribal enterprise that has a primary focus of not only bringing tourist dollars to the community, but also providing economic opportunities for tribal members. So it's a very unique kind of small community, but has been very driven to change the environment, both the economic and the health environment of their community. In our formative assessments of what are the assets in this community, we have done a number of things. In most cases, it's been community forums, in some cases focus groups, but over the years, over the 30 years now that I've worked with Wallapai, there have been a number of forums in which these are the assets that have emerged. There's this common sense of community, that social cohesion and social capital really do determine a strong sense of self-efficacy. The idea that this small tribe in Arizona could manage resources so that they could build a skywalk, so that they could build a river running company. I think those don't sound like health-related issues, but they are in the sense that they really demonstrate community efficacy. The idea that both formal and informal leadership are important influences in the community, that you have elected officials, but you also have elders that really drive some of the decisions. And they have noted in their SDPI programs that engaging elders can be a tremendous influence in having other adults pay attention to what's going on in programs, but also attracting youth to the programs who want to learn more from their elders. They are similar to many Native communities in that friendly competition and basketball and other kinds of games are incredibly important in terms of local resources. And Wallapai in particular has made some very clear determinations through both their tribal council and their health department that they very much see experts and providers as resources, but an understanding that it's local people who are going to sustain the efforts. And I think this is critical in understanding how to manage healthcare programs and education within the community. And they have also taken a very strong stand in their mission statements that their focus is on the people and not the disease, which is easy to happen when your funding's coming out of a diabetes prevention program. It's easy to focus on the disease and not the people. So they have really been driven in understanding the needs of the people. Some of the strategies that they've used is they've used team challenges, which I'll talk about a bit more in the next slide, but it brings, I'm sure, hopefully it brings to mind the Biggest Loser competitions. And they were clearly running these team competitions before the TV shows of the Biggest Losers were ever on the air, so they really have been pioneers. They have healthy family camps. They've engaged leadership specifically to be more visible in terms of their support of programs, and they have worked to develop community norms and policies, which again are more nationwide, tribal nationwide approaches to healthy behaviors. To expand a little bit on the team challenges, it really is a way to leverage that collective efficacy and social capital. Over the years, they've done the team challenges in a variety of ways in terms of the number of people on your team, but the idea is that you get a team together that collectively loses weight or collectively attempts to track X number of miles in a certain amount of time. So a team all has pedometers or keeps track of their times, and after 2 months or 3 months, they then track their they compete to who can collect the most miles. The team names certainly reflect a shared identity, which is critical in keeping everyone engaged, and retention is oftentimes a challenge in health education programs. And the team progress is oftentimes posted in a common area. And this is important because it allows that element of friendly competition to sort of propel the teams to stay engaged, has all the members stay engaged. This strategy is also used in a number of other communities. I know I've worked with Hopi, and they have been probably one of the headliners in terms of making the 100-mile club work for them in terms of friendly competition. Wallapai early on had a HRSA grant, and they combined it with their SDPI grant to have healthy fit camps. And this is their recognition that families really are critical to changing health behaviors in a family, or for individuals, and that they use their local resources to implement these camps, both their environmental resources, since they had a camp facility in their community, and also the cultural capital, the idea that if you bring families together in a camping arena, they not only talk about health education, which is funding these camps, but also to engage elders and other cultural experts so that you reinforce their shared identity and their collective social capital. After the camps, they oftentimes share their camp outcomes in the local newsletter. And this is an effort not only to share their success, but also to recruit new individuals who will want to now come to the camp, because it looks like a camp that is not just about health education, but is also a camp that involves a lot of intergenerational education and reinforces that sense of community for the families involved. Wallapai has been committed and reflective on the idea of community norms and policies. And now, as a result of the SDPI programs and the prominent role that the SDPI has played in the community, is the community also oftentimes expects exercise breaks and walk runs in any kind of community event. So Wallapai has a sobriety event in the summer. It's an annual event, and they expect that there would be a walk run. They have a domestic violence annual event. They have an Indian Days annual event. All those events are now accompanied by physical activity breaks and oftentimes by healthy foods. They have recognized that women in fitness centers has been a normative change that need to occur in the community. So they've tried to make the places friendly so that women will come to the fitness centers, which was previously not something that happened in that community. The store, when it was renovated about 2 or 3 years ago, actually invited the health department to be engaged to help understand how to make more healthy options available for the community, because it would take a certain amount of marketing to get people to expect to walk into the store and choose a healthy choice. The tribe has a healthy food policy in which foods or budgets that are managed by the tribe should only purchase healthy foods as part of the snacks or other kinds of meals that might be served, because that's funding that the tribe has some control over. And probably the most successful tribal policy has been employee exercise breaks. And the way that that works is an employee who elects to exercise during their hour lunch break can actually have an hour and a half. So they have more time to exercise. And this is a very popular approach, and the exercise can be in the fitness center, or it can mean just walking on a walking path and giving you some extra time. So the idea of really changing some of the behaviors in the community and the expectations in the community are really critical to success in the programs here. So I think if you're considering how can your program take on some more strategies in terms of taking a more community-based approach, that it's important to think about what are the existing cultural strengths and assets in your community, what are some of the normative and local behaviors that are in your community, and could those be changed? Could you start shifting towards health fairs or community events that really advocate healthy snacks and approaches to more normative changes? And the other critical piece is, are these changes really sustainable with local resources and personnel? How has the capacity of local people been influenced so that they can manage and run and really contribute creatively to these programs? That their knowledge, I know that in the program I work with at Wallapai, we work on the Healthy Heart program, and when we struggled with recruitment, one of the community members said, we need to get a Facebook page, we need to get on some of these social media so people remember what we have going on. And it just changed our recruitment outreach significantly by being able to get things on Facebook and recognizing that that can be done with local resources and is something people are doing. I'm not forwarding.
So we are
Done?
meditating, you know.
Oh, we're meditating?
Meditating.
Oh. You can go ahead and forward it. Okay, thank you. So I mentioned a couple of resources, both in terms of resilience and cultural capital, which may be new terms for you. I would encourage you to look at some of these resources, and they also have some actual techniques to try how to do the formative assessments. And the last thing I want to do is I also want to thank the kids again in the community, both at Wallapai and other places, who have really been critical in adding the enthusiasm you need to really change the communities that they live in. So that's the conclusion of my presentation, and I understand that questions will be provided, and I'm happy to answer questions now, or if you want to email me, I'm happy to answer them as well. Thank you. So you have to read.
Here's a good question.
Okay.
I'll come by
Okay.
close to you. Okay. So, well, first of all, thank you, Nikki, for your presentation. The background on what's been happening in Indian country, I think, is really helpful, especially at the start of a webinar series like this. And of course, your work is incredible. So it's not just individuals, you're changing communities. We do have some comments and questions. The first one is, I'm a MSW, Masters of Social Work, and a community health worker. Can I get a certificate of participation if I can get the CEUs? I'm not sure about MSW continuing education. As far as a certificate for completing the program, once you do all the answers, there can be I'm not sure what goes out to people in CEUs for outside the chest and nurses and dietitians. So I'm not sure we're qualified for MSW, but often MSWs can use nursing CEUs, and those are transferable. We have a comment. I think the trends in prevalence have shown that's not all individual behavior, which is what these programs focus on. Why don't more of these programs, why don't more of these recognize built environment availability of resources that are not available in rural reservation areas?
Right, well, I just think that, that's probably been, if you're aware of the SDPI programs that are in tribal communities, many tribes have tried to change the built environment, predominantly by putting in fitness centers. I know some have put in walking paths and bike paths. So I think if the staff of the program think about those kinds of things, then it oftentimes happens. I think one of my concerns is it's oftentimes not raised with communities, and they think that an individual approach is what they should be doing. Why don't more programs focus on hierarchy of needs for families? How can how can an individual focus on eating healthy when basic needs are barely being met? And I would agree that that's why I brought up the issue of stress, that it is important to consider what's going on for the individuals, and telling them to bake or fry their chicken, it may be the least of their concerns in the context that they're living in at the moment. And I really think that more work has been done, needs to be done, about looking at the mental wellness, and that the STPI programs actually spend some more time having people talk about food security, having people explain some of the things that are driving their food choices, because I don't think it's all just what's available in the grocery stores. I think there's other things going on there. Where's the spiritual component? So the next question is, where is the spiritual component? Do we ask the patient why they think they have diabetes if we can understand their perspective? And I think that, yes, I think that that idea of maybe in not so much of an individual setting, again, I'm really an advocate of how can we do things more understanding how larger groups are thinking about their diabetes, how, so that individuals don't feel like this is my individual problem. Really the understanding, I think many more communities are coming to agreement that this is really a community problem. And I see way more tribal councils weighing in on diabetes prevention.
As you get, there's a question here about, have you worked with community health workers in your work?
They are actually oftentimes the individuals that coordinate the health community health fairs. We have used them in the family camps. So not as much. Wallapai doesn't have very many community health workers. I have worked with the community health workers at Navajo Nation, and they are very much about how to bring in more of a community approach, and have really been drivers in trying to do things at more chapter houses.
The next question is, do you have any information about programs or strategies for obesity prevention that have been particularly successful with urban Native American populations?
You know, I think the urban American Indians are the ones that have gotten the least attention in the special diabetes programs. And I know that there's the honoring of heart health, and there's the balancing lifestyle curriculums that are there. They have been used in tribal communities, but I think that if you're working in a tribal program, what I would recommend is getting a hold of those curriculums that are free through the IHS website, and maybe piloting them with a smaller group in your urban center and finding out what needs to be modified. I know in rural communities, we even found they needed to be modified in terms of talking about the resources and the kinds of food choices. So that would be my recommendation. I'm not familiar with anything that is specific to urban populations.
This question is going to take you back a bit. Could you talk about how you initially approached the tribe? I know you started working with Wallapai during your doctoral work, but I would add to it, how did you sustain your work with the tribe over these last 30 years?
Doug's right. I did start working with the Wallapai when I was doing my doctoral work. I think what was really critical, and I appreciate the advocates I had in the Wallapai tribe, and they were women that I partnered with early on in the Wallapai tribe who were leaders in the tribal council at Wallapai. And they were really critical to getting the idea forward. And my work did start initially with women, but the approach that I used was the early approach I mentioned, positive deviance. So I was not coming into the community to say, what's wrong? What I was doing was coming into the community and saying, there's clearly people in the community that are healthy, that are able to manage a lifestyle in the community. And we need to know what those people are doing, because they're doing it right, and we are not tracking what they're doing. What we're doing is focusing on those that are struggling, and we're saying, here, let us help you with strategies that have worked outside that community. And so I think it was that positive deviance approach that really allowed me to start working with Wallapai. And I think in terms of partnership, if you're someone who's working outside the tribes and you're not in Indian Health Service or you're not a tribal employee, what the partnership really relies on continuity. And I have worked with not only Wallapai, but several other tribes in Arizona, not being funded. The idea that you got the funding initially, you started the partnership, but the partnership is not reliant on the funding. And so I've been very fortunate in that I have a number of American Indian graduate students now who are able to provide education in the schools and elderly. I have some students that went and worked with injury prevention when Wallapai asked for help in that area. So it seemed out of the realm of what my partnership with them was, but I was able to help meet a service need. So I think it's the continuity. The partnership cannot rely just on the funding.
So the next question, and this might be the last one, have you examined the impact of recent changes to the national school lunch meal pattern on the rates of diabetes in youth and the role of SNAP Ed programs in this area? And also regarding lunch, given that many of the students go away for high school,
Right.
have you noticed any changes in maybe the dietary patterns of children who transition from being on the reservation to then leaving the reservation?
No, I don't. I can't answer that at all. But what I do know is that we're doing a really good job educating kids about healthy choices and not healthy choices. But when the community doesn't model it, the kids don't engage in what we've told them. So that's why I think Wallapai came up with the idea that we really need to change the norms in the community, what the adults are doing. The kids need to see adults drinking water and not drinking pop and eating healthy snacks, because the kids know what you can go to Head Start and ask what are healthy food choices, and they get it. They know that it's fruits and vegetables. So we've done a good job with the education, but as I mentioned previously, education isn't a magic bullet. Education doesn't immediately transfer into behavior change.
Well, this is all the time we have for questions. I'd like to get to our next slide, which one, I hope you all enjoyed this webinar. You found it educational and worthwhile. I'd like to invite you to our whole series of webinars. Our next one will be on October 11th, and it was about youth wellness camps for Native American children and adolescents by Francine Gauchapin, who's a professor in our Department of Family and Community Medicine at the University of Arizona. And then you can see the next two that will round out the webinar series. You can go to the telemedicine website to get updated information, and we will be sending you email reminders to register. Remember, if you want continuing nursing education credits, in order to earn this 1 credit hour of continuing education, you need to complete this. You've been here for the whole presentation, but fill out the evaluation found at cne.nursing.arizona.edu. For continuing education for CHES and for dietitians, you need to receive the completion certificate, fill out the form at this website. You may be able to fill out this form and maybe even show it for your MSW person who wanted a certificate by going to this form and completing it. Your opinion is really valuable for both the Western Region Public Health Training Center and for the Southwest Telehealth Resource Center. Please complete the survey at the end of this webinar about how this webinar went, and here's the link for it. And that is the webinar for today. Again, thank you very much for your participation.